So like I said, I work at the chronic pain service, and here at the pain service, we see a lot of different pains, um, particularly ones that. Oh, hi, Suzanne. Kia ora,
Angela,
kia
kia
ora.
ora no.
Um, uh, and particularly that last a long time, and it's quite a challenge. So osteoarthritis, I wanted to just share a little bit with you today. And this is what we're going to quickly go through. So, what osteoarthritis is, who gets it, who doesn't, what are the big risk factors, what does it feel like, what you might want to be looking out for, and then how do we manage it? How do we assess it, and how do we manage it? So, this is quite a nice picture. I think there was like this ad quite a few years ago. I don't know if anyone saw it. I think it was for Voltaren Rub, and they had like this glass shards like coming out of someone's joint. It looked horrible, right? But
Mhm.
um, actually, osteoarthritis actually looks a little bit different from that. It's not like glass in the middle of your joints. It's actually just a wearing away of a thin, smooth cartilage, and you'll sort of see it there just on one side of the joint. Um, it's it's called hyaline cartilage because it's a thin, smooth layer that can get a little bit worn out. Does that make sense?
Yes.
Yeah.
Yeah.
So if we have another one of the most common places that we might see osteoarthritis is in the hip. And they show all these kind of funny pictures, but this is another sort of picture that will show some of the wearing away of the cartilage. Now, we sort of see about 1 in 10 New Zealanders get osteoarthritis. 30% of people are over the age of 50. And it's interesting because like when I go to pain conferences, there's always a lot of work done, particularly around the knee joints, because that's what we're spending a lot of money on. We're spending a lot of money on knee joint replacements, and so we want to make sure we get them right and with the right people, right? The knee is the most commonly affected joint, and that's followed by the hips and then the hands. Yeah.
I've
Which
had
is,
broad shoulders.
yeah, well, no, not the shoulder.
Mm.
Shoulders.
Yeah. So these are some of the risk factors. And there's some things that we can do, we could have done something about, I guess. And there's other things we really have no control over. Um, and if we look at the non-modifiable ones, the things that we don't have a lot of control,
I can't see
definitely.
that because the little
Oh, your pictures.
pictures of the people are all in the
Oh,
way.
I'm sorry.
Move
Did
it.
that help?
Move your pictures.
Can you
I'm
move them?
sorry.
Yeah,
Can
just
you
use your
move your,
clicker, use your
yeah,
mouse and move them to the side. Um,
I
so one
I've
of the
just had to
biggest
do
factors
that.
is your genes, is your mum and dad. If your
Mm.
parents had osteoarthritis, unfortunately, that's probably one of the biggest factors. Unfortunately, females get more osteoarthritis as we get older. And then there's actually some interesting things. Sometimes we're born with slightly rotated hips or um, slightly rotated knees, and that actually puts more pressure on one side of our joints. So those are the things we can't do much about. Some of the other things are lifestyle things that maybe creep up over the years. And it's interesting. Previously, it was really thought a lot of people, and still a lot of people think of today, is that they think it's a wear and tear problem that if you did, if you overworked, you did too much. But actually, we've found that it's actually probably more a resting problem. If someone's been very sedentary and not moved very much, you're actually more likely to get osteoarthritis. We do see, with that said, we do see osteoarthritis in a lot of joints that have been damaged. So if we take someone like a really high professional rugby player, someone who's had multiple traumatic knee knee injuries, then yes, they're going to have more osteoarthritis, more likelihood. Some occupations where there's a lot of pressure on the knees, so roofers, plasterers that might be on their knees for a lot. We might need to mute Miriam. Sorry about that. How's that? So if your occupation has meant that there's been a lot of pressure on your joints for a long time, then yes, absolutely, those are things that does impact us later on. Smoking, unfortunately, just does not help healing. So it is a risk factor, as well as increased weight is another one. I used to work with an orthopedic surgeon, and he used to say 1 kg on your tummy is about 4 kgs on your knees. So it has a big impact, how much weight we might be carrying around. So what does it feel like? Well, it does feel actually quite different for everybody. It doesn't always feel the same. And I think one of the important things to remember is that it's not actually our joints don't actually have nerve endings in the cartilage. It's actually in the soft tissues around the joints itself that actually cause pain. So you can have worn out cartilage, and we can see osteoarthritis on the x-rays, but it's not actually until the soft tissues around, so the muscles, the joints, the actual joint becomes inflamed or sore, and that's what causes pain. So it's the swelling and inflammation around the joint that gives us pain. Does that make sense?
Mm-hmm.
Yeah,
bone on bone, it hurts.
Well, bone on bone, yeah, that's the worst case scenario, right? With everything gone. But that's actually often the very end, and we don't see that a lot. Normally by then someone's really complained of a lot of pain. But what I'm saying is you don't actually get pain from within the bone. You actually get it from the soft tissues around the joint. Yeah. So what can happen is, even though the cartilage and the osteoarthritis doesn't change, you can have flare-ups and then they can sort of settle down. So osteoarthritis pain isn't always the same. It actually can go up and down because the nerve endings aren't coming from the cartilage. They're coming from the joint around, the structures around. So some people will say, man, I had a bad week or even a bad day, but then, it's not too bad today, so it can really fluctuate. And I guess that's my point. You can also find that there's, you can have a bad year, and then actually things can settle down and not feel so bad. So it doesn't have to be like this, and it doesn't have to be like this. It can be a little bit up and down. Yeah. So these are some of the symptoms that you might feel. Often it's the weight bearing exercises that feel hard, the going up the stairs or going down the stairs wherever there's extra pressure. Squats, lunges, those sorts of things, particularly on our knees, will feel a bit sore. With your hips, it might be rotation. So if your legs rotate a little bit and twist, that's when you might feel a bit more pain. Or again, weight bearing. So when you're walking or sitting for long times or squatting down.
No, where are you going?
But generally, the pain is worse when the joints are disturbed, if that makes sense. Yeah. So if we push too much or if we stretch them too much, yeah. And you'll see these sorts of problems. A lot of people sort of experience this sort of problem. These can become challenges, putting on your socks and shoes. It's all that twisting, bending. Going down the stairs, running, all of that impacting on the joints can really feel quite sore. So, um, so a few years ago, when I was working in some of the orthopedic clinics, a lot of the diagnosis was really purely made on by X-rays. The doctors would look at your X-rays of your joints and make a diagnosis. More often these days, we actually know that it doesn't always add up. You can have people with very bad looking arthritis on the X-ray, but not too many symptoms. And actually, that's why we try and take the whole picture into account. We have to ask about pain and symptoms, and then look at some of those risk factors that you might have, and then examine the joints as well. We don't take diagnosis just from X-rays anymore, because even though we might have osteoarthritis, it doesn't necessarily correlate or mean that your function is really bad. But it is a good way to diagnose. So if you're talking to your doctors and it's sounding like osteoarthritis, it is helpful to sometimes get an X-ray to see how bad that might be. So now let's move on to treatment. I'm just going to mute her again. If we look at treatment, there's a lot of actually different treatments that we look at. There's some treatments that everyone can have, and these are the first line that we tend to go for, which is around education, exercise, and weight control. The second line of treatment is maybe looking at some medications, some ways that we can help manage pain a little bit more. And then last of all, we might look for surgery, which is the knee joint replacement type options. Yeah. So you can sort of see that it might be a different sort of treatment at different stages. So we don't always have to jump straight into surgery, but actually often if we can catch early, we can try and manage. So these are our primary ways of managing. I think it's important to understand our risk factors. Like I said, that 1 kg on your tummy can make, if we can lose that, that's 4 kgs off your knees. It's a good way to sort of spin it. Yeah. Looking at ways that we can exercise and exercise more comfortably. So for some people, it might mean that they need to do maybe less stair walking and maybe more biking. Yeah. You could try water walking rather than walking on the land. And sometimes by strengthening up those muscles, we can support those joints better and people get less pain. And then lastly, weight management, which is really tricky. And I acknowledge that it's not easy. But if there's some ways of reducing and trying to decrease our weight, it can have a significant impact on pain, particularly in our lower joints. There's lots of online resources. This one is from Arthritis New Zealand. So have a look online. There's lots of lovely things that you can look at. The second treatments that you might want to talk to your doctor about is the first one is some creams. There are some creams about like Voltaren Emugel, but also there's another one called Capsaicin that we use quite a bit here in clinic, which is actually like just like rubbing chili. It's a chili pepper cream that we rub onto your joints and can numb the joints. And so that can be a nice option because it's not there's no side effects. There's no nastiness with it, other than don't rub it in your eyes. Because that's a nice that'll cause you some pain. There has been some evidence, but not a lot, around some supplements. There was a big trend towards glucosamine and chondroitin. I don't know if you've heard of those. So that was a big push, as well as I think fish oils. I think some people, but the evidence is a bit sketchy. So I wouldn't be mortgaging the house for it, but it might be something that you might want to consider talking to the pharmacist. Some people find it really helpful. Anti-inflammatories tend to be the main medication that the doctors will use. Unfortunately, they're not that great with respiratory medications and conditions. So don't go taking ibuprofen easily, quickly. I would definitely have a chat and a conversation to your GP about it. Yeah. Steroid injections are another option that sometimes the doctors will use, particularly when the joints get big and puffy. They might be something that they'll use to try and get you going again, and they can be really helpful, particularly to get that short-term pain relief so that you can get on with exercise again. And then lastly, yeah, using your frames, using crutches sometimes just to take some of the weight off it, and then see if you can build up those muscles again. Lastly is the joint replacements, and I'm sure you probably know someone who's had one. They aren't always, 100%, but they certainly can make a big difference. And so for the majority of people, hopefully you won't have to get to this point, but some people do, and it can make a big difference to their life. And generally there's really good results. But yeah, sometimes there can be a few complications, and sometimes we do still see pain following arthritis. One of the big things, following knee replacement, sorry. One of the big things I do say is that the stronger you go into it, into surgery, the stronger you come out. And so even if a doctor has put you on a wait list, it's really good idea to keep those muscles as strong as you can, because they will really help you when you get on the other side. Eat well, stay well, as well as you can, because those things do help. Yeah. So any questions? I feel like I've really raced through. I hope that's been helpful. But feel free to pop something in the chat or unmute.